All right. So last time, left off talking about the hamstring muscles, and we actually specifically left off talking about hamstring strains and how to prevent them. So this time, we'll continue with that theme of hip extensors. And so we'll pick up on one of the lab sheets. You'll notice that first things first, the big one. So glute maximus. Oh, and before I forget, if you're one of the people that's really on top of things and downloaded the slides like early in the week, I put up the rest of the slideshow yesterday, so you'll only see one slideshow, but it has all the rest of the slides, because when I first put it up, I only had the first half done. So I finished it yesterday, so the whole was up. A few times ago, we talked about the gluteal lines on the ilium, that there are 3 gluteal lines, the posterior, the anterior, and inferior gluteal line. Remember that the glute maximus originates posterior to, behind, the posterior gluteal line. The dorsal surface, which is the back side or the posterior aspect of the sacrum, and then what is that? Your coccyx is your tailbone. So essentially it originates along 3 bones. So along the posterior section of bones. It has 2 insertions. So the upper fibers insert into the iliotibial band. Remember we talked about the iliotibial band when we discussed the tensor fascia lata or TFL muscle. So the upper fibers insert there. The lower fibers insert into something called the gluteal tuberosity. So what is that? Gluteal tuberosity, superior or proximal to the linea aspera. So it's just it's a area at the top of the linea aspera. I'm going to click over to the netter slides to show you that real quick. Hopefully they'll pop up. There we go. So you can see the gluteal tuberosity is up here. And so again, kind of lateral to the lesser trochanter, which is here, and then superior to the linea aspera or proximal to the linea aspera, which is here. So gluteal tuberosity is there. So the inferior fibers, oops, wrong one. The inferior fibers of glute max insert into that gluteal tuberosity. So really your most powerful. Remember that all your hamstring muscles are hip extensors as well, but they typically handle the lower intensity hip extension. So your hamstring muscles are the ones you're primarily going to use because you don't have to push that hard during a normal. You're going to use this as well when once you speed up harder, have to get more power. If you're squatting, lift heavier weights. So the higher the load or the more intense the load, the more glute max gets recruited. Also, the farther down you go. So the greater the depth on the squats, if you're doing squat type exercises, max at the bottom of it. So in addition to that, it's also one of the things I mentioned about it. Wednesday about trochanteritis. And so remember that's where the IT band can click back and forth across the greater trochanter. And so one of the things that is tightness in the glute fiber. So either of those muscles pull your IT band close to the trochanter and then can cause clicking and pain. It's between the posterior and anterior gluteal lines. So between posterior, it can insert into the lateral aspect of the greater trochanter, kind of lateral and posterior, and I'll show you a picture of what that looks like here in a second. So in terms of actions, glute medius is primarily an abductor of the hip, so it brings the leg out to the side. And then if you divide it into anterior fibers and posterior fibers, then the anterior fibers do something a little bit different than the posterior fibers. The anterior fibers are flexors, internal rotators. The fibers are extensors and external. It is internal. So anterior fibers are flexors, internal fibers are extensors, external. So the X is. And then glute medius is going to have the same actions, and it's going to have the same basic orientation, where it's going to have an anterior part and a posterior part. Medius and glute minimus are your primary two hip abductors. In the textbook for this class, they talk about the superior fibers. All right, so there's medius, and then there's what it looks like with all the rest of the muscles on it. So again, glute medius. Glute minimus, deeper muscle, resecting or without removing glute medius. Last, anterior and inferior gluteal lines. Also inserts onto the greater trochanter, but more on the anterior aspect than the medius does. So it is a hip abductor. The anterior fibers are flexors, internal rotators. The posterior fibers are extensors, external rotators. So anterior flexor, internal, posterior extensor, external. So between the glutes, so there's a famous quote, I guess, if you will, a few years ago, where Tiger Woods poorly in some tournament, and so he talked about he didn't engage his glutes, and people all yucked it up about that. So what he was talking about was the idea of motion because he wasn't engaging his glutes, as he put it. So one thing I do really want you to know about both glute medius and minimus, because they are role in pelvic stability, especially in that frontal plane. So frontal plane, we're thinking of moving up and down, so ABA deduction. In this case, it's called a tilting of the pelvis. So that is weight bearing, so your leg that your weight is over. When you're non-weight bearing on the other side, so when your other leg is in the swing phase, glute medius and glute minimus are responsible for stabilizing. They're going to contract isometrically. Remember isometric contraction, where the muscle contracts but doesn't lengthen or shorten. They're going to contract isometrically to stabilize the pelvis. They're going to keep you from dropping. And why that matters, if we get, when I step, I get a little pelvic drop. When that happens, that's going to put tension in the IT band, because it's going to pull it tight across the greater trochanter. So you're more likely to have IT band problems both. So in addition to that, anytime the pelvis drops like that, so whether it's laterally or pelvic rotation, that affects the low back. And so if you get a pelvic drop, you're getting compression of the low back on the right side, the way I just dropped on the left, or vice versa, right? So you're getting on one aspect or another of, or one side or another of the vertebral column in the back. And so then that's a problem. So it can also cause back pain. So control of the hip joint, particularly in ABA deduction, is going to be really important for normal walking, normal pain-free walking. In a normal semester, you'll see, walking past the athletic training room, you'll see athletes on the hallway all the time doing monster walks or band walks. They have a band around their ankle and they're kind of squatting down, moving side to side. That's primarily a glute exercise. So to strengthen it up so you can do this. So those are there. As far as the glutes go, the other thing too, so make sure you're familiar when you're looking at the innominate bone with the origins of the glutes, because I was working on the quiz bank yesterday. And so there are questions in there about identify the origin of glute medius, identify the origin of glute kind of stuff. So just make sure you're familiar with those. All right. Deep six. Those are all in one big box on that lab sheet. So for the deep six, you don't have to know their origin or insertion, but I do want you to be able to identify. No origin insertion, but be able to pick them out on a picture and then know what they do. So the reason they're deep is that, or the reason they're the deep six, to glute max. So in order to see them, you got to pull glute max off or hide it on the anatomy app, and then you'll be able to see the deep six external rotator. So they're on the posterior, deep to glute max. And so obviously each of them. And for the top four, so the top four muscles all have actions: external rotation, extension. And the way I've laid them out is superior to inferior. So piriformis is the most superior of the six muscles. So where it is. So again, we've taken off glute max. You can see glute medius here. And then here's your hamstring muscles. So here's semitendinosus right there. There's biceps femoris. So the deep six are these muscles here, and then one that you can't see on this view. So the first one there, piriformis, again, extension, abduction, but primarily external cuff, supra, infraspinatus, and teres minor in the shoulder. They also all insert on the greater trochanter. Again, you don't have to know origin insertion, but they do all insert on the greater trochanter. So again, akin to what we saw in the shoulder, where the external rotators all insert greater tubercle. So one of the other interesting things about piriformis, not pictured on here, but you have a big nerve, because I didn't put the nerve structures on here, but you have a nerve called the sciatic nerve that runs out through that greater sciatic foramen. So we talked about the greater sciatic notch, that candy cane looking thing. So just underneath that is your sciatic nerve, if we put the nerves on there. And so when that nerve pops out, it actually runs underneath the piriformis muscle. Sometimes athletes that are engaged in sports with a lot of change of direction, so like your soccer players, where they're going to be players, basketball players, will sometimes present with like shooting pain in the backside of their leg. Normally we associate shooting pain down the leg with a disc injury, and certainly it might be that, but which will cause it to send signals when it shouldn't be. The brain interprets that as kind of a burning pain or tingling or numbness on the backside of the leg, kind of on most of the posterior aspect, but then also on the lateral aspect of the leg as well. So it's called piriformis syndrome. Superior gemellus and inferior gemellus, and depending on which books or sources you use, sometimes they'll flip them. So it'll be like gemellus superior instead of superior gemellus. I say them both ways. So superior gemellus, again, same actions as piriformis: external rotation, abduction, extension. And so there we go. The piriformis. Piriformis from the sacrum, the lateral aspect of the sacrum. Superior gemellus originates on the ischial spine, or spine of the ischium, and they all insert the greater trochanter. The next one is obturator. So remember that the big hole in the innominate bone is the obturator foramen. In all of us, there's not just a big hole there. There's actually a membrane that fills in that hole, and then on the external aspect, or more aspect of it, you have obturator externus, but then on the internal aspect, obturator internus. And so obturator internus there arises from that inner aspect of that obturator membrane. It actually runs the gemellus, obturator internus, and inferior gemellus. Their tendons all run together. They all the same. So then there's inferior gemellus. So again, inferior gemellus is one of the ones that are a little further down, rise from the ischial. And then we get to the largest, well, second largest of them, is quadratus femoris. So now the still an external rotation, but because it's so far so inferior, inferior or distal, that it switches its action from being an adductor for the So those are the 5 that are in the back. And then the last one is our obturator externus. And you have to look at it from. So now you're going to get an anterior view. Obturator externus is I have to take off the hip flexors. So you got to take off iliopsoas. Obturator externus there on that external part of. In terms of the quiz bank, it'll be one of those, like, you'll see a picture like that with the muscle highlighted. Which muscle is this? So from a practice standpoint, external rotation, abduction. And the bottom 2. And where those come into, class 2, lady landing from a jump where her knees are buckling medially, and we talked about that was a danger to the ACL and also to the MCL in the knee. And so one of the things that we discussed as part of that was she's probably weak in her abductors, so her glutes, so glute medius and minimus in particular, but also in her external rotators. And so if you can strengthen up the external rotators, you can control that knee buckling toward the midline when athletes land from a jump or when they land while running. And so strengthening up these muscles is sometimes important in the athletes that have poor hip control, if you will. All right. And just as a picture of where they all insert, so you can see what you're looking at, a view of the right hip, the superior view, so you're looking at it from the top. Up here is the front, down here is the back. And so this is the greater trochanter here. So you got gluteus minimus inserting on the anterior aspect. All of this is gluteus medius there. Then you can see they insert top to bottom, piriformis there. Again, obturator internus and both of the gemelli, superior, inferior, insert basically the same spot. Way down here, again, that's where we've got. All right. So those are switching groups. So your adductor muscles are more colloquially known as your groin muscles, because hip adduction is bringing your leg together, bringing bringing your legs toward the midline, right? So your groin muscles, the largest of them is adductor. Magnus means the great one, so it tells you what it does. It's an adductor, and it tells you that's the largest of them. So as it's the largest, it also has the largest origin. Adductors originate adductor group. All of your group originate somewhere on the pubis. So adductor magnus originates from that so big that it moves on to or continues on to the ischium. So it actually spans 2 parts of the dominant bone. The rough line on the posterior aspect, kind of along the midline of the femur. So adductor magnus inserts along the medial lip of the linea aspera, and it runs the entire, which is here. So this little thing, which you don't need to know this, but this is called the adductor hiatus. And through this goes your femoral, so the leg, through the femoral artery. The femoral artery is in your groin, and it won't be pictured on the leg, goes through this adductor hiatus and just to the and becomes the popliteal. of your knee, you have a really big artery, the popliteal artery, that sometimes it's difficult to do, but you can take a pulse there if these knees really kind of feel behind their knee. Sometimes you can find a pulse. That's their popliteal artery, which again is a continuation of the femoral artery. So the femoral artery goes through that little hole, and then the rest of the adductor magnus inserts here at the adductor tubercle. And you can see it continues a little bit up onto this ridge, but generally it's just discussed as the of linea aspera adductor tubercle. What's it do? Obviously it's an adductor, but because of where it is and how large it is, the anterior part is involved in flexion and extension, and then the posterior fibers are also involved in external rotation of the hip. One of the interesting things about adductor magnus, I'll show you, that's what it looks like with the rest of them on there. Although I've taken off the next two muscles, adductor brevis and longus, to be able to see. But one of the interesting things about adductor magnus, if you've ever watched people who are, let's say, novice lifters in the weight room, one of the things that they'll do oftentimes when they squat, so if they're doing any kind of front squat, back squat, whatever, when they drop down and they're near the bottom, their knees will buckle in and then they'll stand up. Why do they do that? The reason they're doing that is because they're recruiting adductor magnus. So again, adductor magnus is also a hip extensor. So basically they're engaging magnus to try to, in its action for hip extension, to try to push themselves back up, but they haven't engaged the abductors, particularly glute medius and glute minimus, to help contract isometrically to stabilize the hip and prevent abduction motion. So what do you do to fix that? Put a band around their knees. It's really counterintuitive, but if you put like just one of the Therex bands around their knees, that's actually going to pull their knees toward the midline. That's going to make them engage their glute muscles when they squat, and then so they'll quit doing that as much. It's just a helpful thing to do. The other thing is, if you've ever squatted a bunch and you notice you're kind of sore in your groin, that's why. It's adductor magnus's involvement. You're going to get that typically the farther you go down. So deeper squats tend to engage magnus more. All right. So there's some, I guess, you'll see differences in where the origin is here. The anatomy app describes it as the middle part of the superior ramus. Sometimes it's described as being on the inferior ramus, but we'll stick with this. And so it's also going to insert along the linea aspera. It is actually going to insert on the distal aspect of the linea aspera. So it inserts in the same line, but just more proximal to adductor longus. So it's longer than brevis because it inserts further down the femur. So that's what makes it a long muscle as opposed to brevis. Because of its orientation on where it originates on essentially the anterior aspect and then runs to the posterior aspect of the leg, so an adductor and flexor. In terms of the origin, so you can see adductor longus right here. And so that's why sometimes it's classified as the superior ramus, sometimes inferior. But anyway, that's its origin there. All right, oops, again, messed that up. And then last one, adductor brevis. So definitely originates from the brevis. Also inserts along the linea aspera, but more proximal to the adductor longus. An adductor and a flexor. So your three adductor muscles then, adductor magnus, longus, and brevis. And all three insert along the linea aspera, which is definitely something I want you to know and something that so some of the questions will be like, identify the insertion of the adductor along the linea aspera. Which of these muscles doesn't insert along the linea aspera? All your adductors do, so it's any one of the muscles that's not an adductor. And so there's brevis. So you can see it's hidden behind. It's hidden there. And then the other thing. So that runs the whole length. That's adductor magnus insertion. Adductor brevis is the top part, and then adductor longus is down here. All right. And the last of the groin muscle, gracilis. So gracilis along the pubic symphysis, also that inferior pubic ramus. It's going to insert an the pes anserine is the medial aspect of the tibia, just medial to the tibial tuberosity. Again, another question I like to ask, what are three muscles that insert at the pes anserine? And the answer to that question, sartorius, gracilis, and then semitendinosus. So the three muscles that insert at the pes anserine, sartorius, gracilis, semitendinosus. So the mnemonic for that, or the only one I'm aware of, is say grace before tea. And so all three of those muscles at the hip, and then a flexor and an internal rotator at the tibiofemoral joint, which so are the other two muscles that insert at the pes anserine. So sartorius and semitendinosus are both flexors, tibiofemoral, and then internal rotators, tibiofemoral. So as you would expect, the muscles that insert there share some action. All right, so that's musculature. Now, to the knee. View of some of the bony landmarks that we talked about a while back, probably Monday. So in terms of the femur, so now you're looking at the distal aspect of the femur. So there's condyles and epicondyles. So remember that the condyles of the femur are the most distal aspect of the femur. So the condyles are what actually on top of the tibia when you're standing. And then the epicondyles above that, or more accurately described, proximal to that. So if the condyles are covered in articular cartilage and sit on top of the tibia, then the epicondyles are just above that. So the medial condyle, and I know this is medial because it's a right femur viewed from the front, but if I didn't know that, I know this is the medial condyle because it's on the same side as the femoral head. So the femoral head is always medial, so then this is the medial condyle, and then where this really obvious ridge is that the hyaline cartilage ends, everything above that, or proximal to that, is your medial epicondyle. So this is the medial epicondyle here. And then same concept over here, lateral condyle. You can see where the hyaline cartilage ends, and then lateral epicondyle over here. Other things, intercondylar groove. So the intercondylar notch is on the posterior aspect, referred to as the intercondylar fossa. So the intercondylar notch tells you where it is, between the condyles, and so it's a big notch or fossa indentation there. So that is your intercondylar notch. That's the intercondylar groove is this space here. So that's where your patella or your kneecap. So whenever you flex the knee, your patella is actually going to seat against little groove. One of the things about the intercondylar groove, so the lateral condyle of the femur is upper incline to it, and the idea there is to help improve patellofemoral stability to keep it in line with the femur. All right, there's those. Okay, so let's talk about, so this should be, so as far as the fibula go, there's not a lot of landmarks you need to know for now, so we're looking at just the proximal aspect. In the lower leg, bones, the tibia and the fibula. As always, you're looking at a right pair of those bones from the anterior aspect, so right view from the front. The tibia is the more medial of the two, so the tibia is always closer to the midline, and it's the much larger of the two. So the tibia is sometimes the lateral aspect, that's your fibula, so it's the small bones. So on the fibula, to find the 3 landmarks that are proximal, we actually have to look at the lateral aspect of it. On the fibula, and the first one there is the apex. And the apex on this model is not super obvious. It actually is pretty obvious on the bones in the lab, but it's not super obvious here. But the most proximal aspect of your fibula has a little point to it up top, and that's called the apex. So it's a little point up top. And then the whole thing here, all of this proximal aspect, that's the head of the fibula. And then where it narrows is the neck. So not a lot exciting going on at the fibula. For now, most of the biceps femoris, the lateral of the fibula. On the tibia, I got some more important stuff. So we'll go back to that anterior view. So the femur has condyle. So the medial condyle of the tibia is this medial articular surface here. I think I have a superior view. There we go. So this is a superior view of the tibia. The top part is the anterior aspect of the front. The bottom part is the posterior aspect of the back. So this is the medial aspect here, and this is the lateral aspect. So all of this is the medial condyle. So essentially the medial half of the bone is the medial condyle. And so it articulates with the medial condyle of the femur. And then we got the lateral condyle, obviously the other side. So the lateral condyle, the smaller of the two there. And it's going to articulate with the lateral condyle of the femur. Other thing, intercondylar eminence. So intercondylar, between the condyles. Eminence is something that projects out. So the intercondylar eminence, and you can kind of see it from these little projections here. So right in the middle of your proximal tibia, you have 2 little points. And they're in this region here. They're kind of indicated by this and this. And so that's the intercondylar eminence. The significance of the intercondylar eminence is your PCL and search behind it. Go back to the anterior view. So this rough area here is the tibial tuberosity. In most people, it's obvious. There's a pretty obvious bony knob there on your shin, proximal aspect of your shin. So that's your tibial tuberosity. What group of muscles inserts there? Nope. The quad group. So the quadriceps group, the muscles on the front of your thigh that extend your knee, rectus femoris is one of them. All of the quad group inserts tuberosity. Where we discussed it before is when we talked about Osgood-Schlatters disease. That particular apophysitis happens at the tibial tubercle. Gerdy's tubercle is on the lateral aspect. So Gerdy's tubercle is over here. There's a flat surface that's kind of angled about 45 degrees back from the frontal plane. And so that angled surface there is Gerdy's tubercle. The IT band. And remember that the IT band is the tendon of insertion of TFL and glute max. The last thing on there, the pes anserine, we've talked about already some this morning. So the pes anserine is this area over here. So again, the medial aspect of the tibia, medial to the tibial tuberosity, which is here. So all of this is the pes anserine. And remember, 3 muscles. All right. Okay, so last thing for today. So we're going to high school athletic trainer. A football player or receiver comes to you complaining of knee pain. And so when you run through your normal questions, he's like, I don't know. I don't remember doing anything specifically, but it's been bothering me for a couple of weeks. Sometimes, in terms of what's bothering me, sometimes it feels like my knee catches or gets stuck. Other times, I'll be sometimes just walking between classes or maybe even at practice running a route. It just feels like my knee gives out. And it's, weird. And so I stand up and it just feels like it kind of has this general pain in the knee. And he has some swelling in the knee. So I have a picture of a swollen knee. So his knee would look like the one there on. So it's a little swollen. midline pain. Find the top of the tibia, and so he's got some pain just right there along the middle. So, any guesses as to what he might have done? It's a pretty non-specific set of symptoms. General knee pain, can't point to an inciting incident. Nothing particularly makes it better or worse. Again, feel some catching or giving out and some swelling. The answer to that question, because I've bored you all to death with muscles, is he probably has a meniscus tear. This guy, hyaline cartilage, has more fibers in it, has more collagen fibers and lower water content. So there are two rings of fibrocartilage that sit atop the tibial plateaus. So you've got a medial meniscus and a lateral meniscus. One that's highlighted there is a medial meniscus. To get a good view of it, just switch leg, but you're looking at it kind of a 3/4 view from the back. So the front of the tibia is over here, and then obviously the back is back here. So that's the medial. In terms So they're a lot thicker on the outside, and then they become thinner as they move into the joint. This is larger than the lateral meniscus, so it's kind of a semicircle shape. It only covers, depends on the size of your meniscus, somewhere between 50 and 75% of the tibial plateau, as opposed to the lateral meniscus. It's smaller because the condyle is smaller. It covers more of the plateau. The lateral meniscus covers as much as 95% of your lateral tibial plateau. So the meniscus, their first job, as you can see there, is to promote joint. One of the big factors in that is the shape of the bones. Well, in the case of the tibia, the medial condyle is a little bit concave, so it caves in a little bit, but not near as much as the femur is convex. So the medial condyle of the femur really curves out. On the lateral aspect, the lateral that, because there's not a lot of like bony cup, if you will, on the tibia for the femur, there's not a lot of bony overlap, so the knee is inherently a fairly unstable joint. And so one of the jobs of the menisci then is to deepen that articulation. They increase the surface contact between those two bones. They increase the stability of the joint. So if you remove the mobility in the knee increases almost 60% in terms of forward and backward motion. So menisci have a really important role in joint stability. They increase that surface contact area, and also by doing that, they increase shock absorption. So they compress whenever the femur is on top of the tibia, and they kind of stress, so they come out, and so that then, like during walking or running, into the femur. So that's their other job. In terms of vascularity, remember that means blood supply. So with the menisci, superficial third of it actually does have pretty good blood supply. So for whatever reason, zones are called, there's always two colors. So the outermost zone, or the most superficial zone, is red. Red means good blood supply. Then you have the middle third, so kind of in through here. It's called the red-white zone, which means it has some blood supply. And then the innermost zone is called the white-white zone. I don't know or not. So anyway, white zone. Synovial fluid. So whenever you scoot around, then that's what's going to nourish those innermost or the innermost part of the menisci. Why does vascular tissues that don't have supply don't heal very effectively? So where that matters then is if you get a tear of the meniscus in here, got no blood supply, it's not going to heal. Those two tears further out or more superficial, because there's good blood supply, those have some chance to heal. So it's possible you'll get some healing with those. the two menisci. In terms of the collagen structure, so you're looking at, this is kind of generic medium, in essentially 3 different directions, or 3 different types of fibers, if you will. So they're all the same collagen. It's almost all type 1 collagen. But you've got circumferential fibers that run kind of the circumference of the meniscus. And so those fibers, as you get compression between the femur and the tibia, again, those are going to be the ones that really bulge out. And so they're responsible for resisting most of the compression. And then between the circumferential fibers, you have radial fibers. They radiate, folks. And so the radial fibers, you can see some of them here, their job is to hold fibers together. So you got fibers that run kind of in a ring around the outside, and then radial fibers that run perpendicular to those and hold them together. And then atop those, you have that mesh network, which you can see here, where the fibers run in a bunch of directions, and that helps provide a nice smooth surface for the femur to. They help increase, not lubrication per se, but decrease friction. Let's go with that. And then different kinds. Okay. So we have the far. And those are pretty similar to the transverse tears, which are the second most common. It's like a tear. These are sometimes called bucket handle tears, because what ends up happening is this most inner part of the meniscus will. And so when the athlete was describing to you that he feels like his knee gets stuck, what has happened is that part of the meniscus has moved into the joint where it's not supposed to be. So it's like right in the middle of the tibial condyle. And so then that has not allowed his femur to slide on his tibia. That catching sensation. PCL, and the cruciates are probably still intact. Cartilage that they're not used to produces that knee giving out type of a sensation. Why does he have swelling? You know. Inside of the joint is going to cause swelling. It's going to cause increased synovial fluid production, and so then that causes it to bulge out. And the appearance of that then is just the margins of your patella, of your kneecap, just aren't as well defined anymore. So it's a very similar swelling to what I showed you, except that the picture that I showed you is probably a more extreme swelling than you would see with somebody who just has a meniscus tear. It's usually not quite that obvious, but just to make it more obvious for demonstration purposes, that was a meniscus tear. There's some puffiness. It looks a little bit different than the other side, but it's not going to be a dramatic difference between. Same muscles again, because some of the hip muscles are also knee muscles. And then we'll also talk about the getting into the nervous system. So we'll talk about nerve conduction.